All right, we are live.
All right. Well, good morning, everyone. Looking great. Wishing you all a very happy holiday season. I'm Valerie Sullivan. I am chair of the Group Insurance Commission, and this is our December meeting. It is our last meeting of the year, and it is so nice to be here with all of you. So as a reminder, we are live streaming, and that means that we are going to introduce the commissioners who are here today. So Andrew, if you want to go ahead and name off who's here, that would be great.
Sorry, I
Maybe
was
not.
on mute,
Yeah, that's okay.
and I'm working on my video. Well, obviously the chair is here. Vice Chair Kaplan has joined us. Our A&F designee, Cassandra Roeder. Our DOI designee, Rebecca Butler. Commissioner Toby Choate, Commissioner Tamara Davis, Commissioner Joseph Gentile, Commissioner Patricia Jennings, Commissioner Melissa Murphy Rodriguez, Commissioner Tim Sullivan, and I think that's everyone who has joined right now. If I've missed someone, could you please say so?
Did we acknowledge Patty Jennings? I think she's here. Yeah.
I may have not said that. Thank you. Yes, she is with us.
All right. Well, thank you, Andrew. And so at this point, I'm going to turn it over to our executive director to review the agenda.
Thank you, Madam Chair. Good morning, commissioners. Thank you for joining us. So we have a fairly busy agenda today. In addition to our routine items, minutes, executive director's report, we also have our FY25 preliminary cost increase. Of course, this is the beginning of the process for us to develop our rates and plans and plan design for the coming fiscal year. So today is an inform object for us to bring to you today. The second item regarding regulatory amendments that are related to our ongoing effort to reduce our waiting period for new benefits, which Andrew will walk through. And since we are now past the December 1 deadline for municipalities and other entities to notify us that they would like to join or to leave, Mike Berry, our Director of Government Affairs, will present on the activity on that front. So that is our agenda for today.
All right. Well, thanks, Matt. So at this point, I'll entertain a motion to approve our minutes from our November meeting. And if you weren't with us in person in November, it was really lovely to be back together. And I want to thank the staff of the GIC for pulling that in-person meeting together. So if I have a motion to approve the minutes from that meeting.
So moved.
So I think Bobby was first and Tamara was second. So thank you. And so I'm a yay. And then Andrew, I will hand it over to you for roll call.
Thank you, Madam Chair. Vice Chair Kaplan?
Yay.
Commissioner Roeder?
Yay.
Commissioner Butler?
Yay.
Commissioner Choate?
Yes, approved.
Commissioner Davis?
Aye.
Commissioner Gentile?
Yes.
Commissioner Jennings?
Abstain. I was not present.
Commissioner Murphy Rodriguez?
Yes.
And Commissioner Tim Sullivan?
Yes.
I believe that's everyone in attendance. The motion passes.
Thank you, Andrew. Appreciate that. So let's move on to our agenda then. We've got a packed agenda. Rates are always an interesting time for us, so I'm looking forward to hearing more.
Thank you, Madam Chair. So we will start off with a few brief highlights of the Executive Director's report. Of course, you have the written report, but per usual, will highlight a few items. In the legislature, we continue to track a bill that relates to prescription drugs, access and cost and affordability. Last month, the Senate passed Senate Bill 2499, an act relative to pharmaceutical access, cost, and transparency. The action now moves to the House to see what they will do on this topic. I would imagine that they would take up their own version of a bill in the new year before they attempt to reconcile any differences. We remain in contact with both the House and the Senate about the issues in the relevant legislation, in particular as they relate to the GIC. So more to come on that. On the municipal front, of course, as I mentioned, during today's meeting, we'll hear from Mike Berry. But Mike has also been in touch with a variety of communities who have been exploring joining the GIC. He's been a great resource to cities and towns that have been evaluating this option. He recently participated in a broad public meeting in the town of Hamilton that is indeed evaluating their options. And he presented a GIC 101 for that. So thank you, Mike. And as we did last year, we will be participating in the Massachusetts Municipal Association annual meeting and trade show in January. We did this last year for the first time in many, many years. And it was an excellent opportunity for us to engage with current GIC member municipalities, but also meet others to talk to them about the benefits of joining the GIC. So we look forward to that. And again, thanks, Mike, for doing all the work there. On the communications front, per usual, we've provided a detailed overview of all the work that's happening in this space, with thanks to Leslie Montero for leading those efforts, working with Erica Schiavelli, our Deputy Executive Director. But I'd just like to highlight a few items. First, we have set the GIC 2024 annual enrollment dates. They will take place April the 3rd and close on May the 4th. And planning internally is already well underway. We're preparing our benefit statements to make those available to our members so that they understand what their current benefit lineup is. And as we have over the last year or so, we're really trying to leverage the MyGIC link member portal to make this information available. We also are, we've planned the dates for our public information sessions, which of course play an important role in this process. They will be on Tuesday, January 23rd. We will have 2 sessions that day at 12 noon and 6 p.m. and Thursday, January 25th at 9 a.m. So what we've tried to do, of course, is to provide a variety of different kinds of times for those who might be able to do it at noon or first thing in the morning or after work, and that has proven successful. So we will hold these again this year virtually via Zoom. This has been an excellent opportunity for us to present our preliminary cost increase that we're presenting to you today, as well as any recommended plan design changes, which we will be back to present to you on in January. It's a great opportunity for us to give, to hear from our members, to hear feedback, to answer questions live as they happen through the Zoom chat feature. These have been very successful, so we look forward to that. After those sessions conclude, per usual, we will provide a summary report to the commission before we move forward with a vote on plan design. As always, we encourage commissioners who are able to join one or more of the sessions to do so. We always benefit from having you there. So more information will be forthcoming regarding how to register for the sessions. We'll be doing that in early January. And of course, every session that we hold will be recorded and posted on our website so that those who are unable to attend can get the benefit of that information. So that is my summary of the executive director's report, and I am happy to take any questions before we move on to the calendar.
So I have a question. I'm wondering if you would consider perhaps another public information session or another session on a different day, because Tuesdays, Wednesdays, and Thursdays are heavy in-office days for state employees, and it may be more difficult for people to, attend those sessions. So I'm wondering if a Monday or a Friday, because more people work from home on those days, and it may be easier for people, because the heavy in-office days are typically, a lot of collaboration meetings and team meetings. So if you might consider that.
Yeah, that's good feedback. Thank you, Bobby. We'll take that back and see if we may be able to kind of jigger the calendar a little bit to make that work. Thank you for that feedback.
Thank you.
And I think I may have misspoke earlier. I apologize around the dates for the annual enrollment. It actually ends on May the 1st. I think I may have said May the 4th, but it is actually May the 1st.
All right. Well, thank you, Matt. I don't see any other questions, so we can keep moving.
All right, so we'll do a quick review of our calendar. As you can see here, as I mentioned at our last meeting, we wanted to move it to a fiscal year structure, which really more accurately tracks the rhythm of the work that we do for the staff and for you. So this, as the chair noted, is the last meeting of our calendar year 23. And we have included in your commission packets the preliminary calendar for 2024 commission meetings. So please take note of those. These dates will be posted on our website in the coming days, and we'll continue to update this calendar slide for future meetings as we set those agendas. As I noted, today we'll present the expected FY25 preliminary cost increase. And this is the first step for the fiscal 25 plan year. And so in January, we'll be back to present on any proposed plan design changes as an informational. Again, as I noted, we will present all of that to our members in the public information sessions before we come back to the commission on February 15th to report back to you on what we heard and learned during those sessions. And at that meeting also be presenting a recommendation for plan design changes for a vote. Then, in order to accommodate the deadlines ahead of annual enrollment, we will hold a second commission meeting in February. We sometimes do the second meeting in early March, but this year, just to accommodate some of the deadlines and the work that needs to get done, we're moving that back to late February. And that will be the vote on FY25 rates for our plans. And we will not hold a meeting in March so that our staff can focus on all the work that needs to happen before we launch our annual enrollment in April. So that is our calendar. Happy to take any questions before moving on.
I don't see any, Matt, so you can keep moving.
Okay. So we'll move now to our first media agenda item. This is a big item for us. I'll turn it over to Jim Rust, who will introduce our presenter from WTW. Jim?
Thank you, Matt. As you've heard a few times now, every year at this time we present the preliminary aggregate cost increase, which begins the process for arriving at premiums for the next fiscal year, which is, believe it or not, fiscal year FY25. Over the course of the fall, we have worked closely with our partners at WTW to formulate our FY25 budget submission and to do the foundational work for the FY25 premium setting. Vince Kane, who leads the actuary team at WTW, is here to present where we are in this process. And with that, I will turn it over to Vince. Vince?
Thanks, Jim. Thanks, Matt. And good morning, Madam Chair, Commissioners, and other members of the GIC staff. I'm Vince Kane. I lead the financial team at Willis Towers Watson in developing the first look at FY25. If we can move on to the next slide, I'll cover sort of why we're here today. So every time we go through this process, we are working with the GICs, medical carriers, PBMs to price out the full cost premiums for the upcoming fiscal year. So this year, as Jim mentioned, we're looking at FY25. We are developing premiums for the non-Medicare as well as the Medicare cohorts. So, what is a full cost premium? Well, that's the sum of money that is expected to cover the projected claims, administrative fees, and other non-claims charges for the upcoming fiscal year. And that's including both the Commonwealth's portion as well as the contribution amount for members and retirees. Out-of-pocket costs are not included in these premiums. So office visit co-pays, pharmacy co-pays, deductibles, and all of that at the point of care are not part of this process. For the most part, we are developing self-funded premiums. So, that means that the state is effectively on the hook for the cost of care, the utilization of the members, and the prices that are charged by hospitals and providers. There is one exception, and that is the 0.32 Medicare Advantage plan, which is fully insured on the medical side. So as part of our process in developing the premiums, we look back at emerging experience as well as complete prior fiscal year experience. So we're looking at FY23. We're looking at that claims experience and demographic data, membership data by plan, and projecting that forward to FY25. If you want to go to the next slide, we'll take a look at the initial result. So, in the center there, you can see that what we're looking at now is higher than what we've had in the past. We're coming in with an expected aggregate increase of 9.6%, although, we're still working to finalize a number of elements of our projection, which I'll go into shortly. And so we have a range of 8 to 11% shown here. This is meant to represent the weighted average across all of the plan options for GIC non-Medicare members as well as the Medicare retirees. You might note here that the market benchmark is a lower range on the top here of 5 to 9%. That market benchmark is a little bit higher than last year. And, it really represents kind of our best estimate for likely outcomes, primarily based on a survey that we conduct every year. The survey results from the prior best practices survey indicate a 6% trend for 2023 and 6.4% for 2024. That's based on survey responses from about 450 clients covering 7 million employees. Now, that survey was done earlier in this year, and we'll speak to this in a moment, but we found that we believe that, if the survey responses were collected later in the year, that the range would likely be higher. So we've seen particular drug trends, which we'll discuss, that have driven higher emerging experience throughout the course of 2023. And given the timing of our pricing process for the GIC, we're capturing more of that experience. And I think that's part of the reason why we're seeing a higher result for GIC compared to the survey responses. Another point we like to make in the benchmark trend range is how that compares to merged market increases in the state of Massachusetts. So last year, I think we had a 7.6% merged market increase for 2023. The year before that, it was 6.9, and the year before that, 7.9. So we've generally seen merged market increases in the range of 5 to 12% in recent years. This most recent year, for 2024, the merged market increase was 3.2%, with a range of a slight decrease to about a 10% increase. Now, even though the merged market full cost premium increase, and that's an insured marketplace, was so low, the pricing trends that were used in that analysis were 7.1% for medical, 9.5% for drugs, so averaging out to about 7.8%. That's actually a higher trend than what we're using for GIC members and retirees. Our starting point in doing our pricing projection was a trend of about 5.8%. What we found in going back to the vendors is that there was a significant increase, particularly in unit cost component of trend, such that the overall weighted average trend increased from 5.8 to 6.8%. And I would say, more than half of that trend is due to unit cost and a mix of services, but has a compounding effect over 2 years. So a 1-point increase in our pricing trend leads to about a 2-point increase in the overall forecasted rates. On top of that, the experience that we looked at for FY23 emerged worse than expected. So, that added about 3 percentage points overall to our pricing projections. And as a result of rebasing our claims, plus adding the compounded trend, we were already in the hole from a FY25 perspective. Offsetting this, and the good news is that we had about 3 to 4% reduction in the total budget, mainly due to improved rebates under year 2 of our pharmacy contracts with CVS for both the non-Medicare and Medicare folks, as well as improving subsidies for the Part D EGWP plan. So, the pharmacy coverage that the Medicare retirees have has under the hood sort of an EGWP arrangement where we receive subsidies that offset the premium, and those subsidies are increasing, partially due to the Inflation Reduction Act, which was passed back in the summer of 2022. At the end of the day, though, we also had to put in an adjustment for emerging drug experience beyond which we would have projected using our normal pharmacy trend. And that's for a class of drugs which we took a drill down on separately, known as GLP-1s. And, you might have heard of drugs like Wegovy or Zepbound for weight loss. We found a pretty significant increase in utilization and costs related to these drugs beginning in the first half of calendar year 23. And we've actually looked at emerging claims through November and projected that entire drug class separately in the FY25, which is basically going to lead to about a 1.5 to 2% increase in the overall expected aggregate increase. So that's a summary of sort of how we end up at this initial view of 9.6%, how that is framed relative to the market benchmark. Our work is not done. We always go back to the vendor partners and get a reforecast of medical trend to make sure that we're capturing any additional contracts or negotiations that are going on between the carriers and the providers, knowing that unit costs tend to drive these short-term trends. Even though we're seeing inflation cool off, we're seeing continuing increases on medical unit cost trend due to the long-term nature of a lot of these contracts and the fact that they're renegotiated every 2 to 3 years. We'll be making separate adjustments as we collect continuing data on the GLP-1 drug class, refining our rebate estimates and EGWP reimbursements, and then be prepared to restate the 9.6% going into January. Finally, this is a status quo view. So if we decide to put in any plan design changes, those will have an impact as well on our final projection, and we won't be voting those in, I believe, until February. So I'll pause there. I'm sure there's a number of questions.
So Vince, I don't see any questions. I'm just curious if you can talk a little bit about any support that the GIC constituents could get around these GLPs, or help us understand, how many of our members are using it? Are they finding value? Are they having challenges getting the access?
Yeah,
If we're spending, and if we're spending more money, are we getting value from it? So I think, many of us care, all of us really care about our members and if they're getting the outcomes they need. And yet we're also concerned, or at least I can say I'm concerned about the rate increases. And the stat you used on the GLPs, just one category driving that much of a rate increase, are we getting value for it? And I don't know if others want to speak up. Toby, I see your hand is up.
Well, I was at a more macro level, but I think that GLP is a really interesting question, but it will get to the same question I have. But in a macro sense, these rate increases, the band that you're dealing with, that you presented us and then expected, and then the underlying GLP growth, is that unique to us, or is everybody facing, approaching 10% increases?
Yeah, let me answer parts of those two questions first, and then we could talk about some of the clinical benefits of the drug class. So we had about 2% of the non-Medicare membership using these drugs in FY23. That is very reasonable compared to other plan sponsors that cover these drugs for weight loss in addition to clinical indications for diabetes. Part of our forecast for FY25 acknowledges that there's going to be continuing increase for plan sponsors that cover these drugs and continuing costs. So the GIC is not unique here. We're forecasting about 3% of members using the drugs by FY25. However, some sort of normative guidance out there suggests that for, the overall population of the United States, where I think obesity rates are perhaps at 30%, we're expecting about 20% utilization. So that's about 6% of kind of a commercial population. So we're not even there yet. And we're continuing to monitor the utilization of these drugs. So one other quick comment related to the market benchmark numbers I cited, especially for the merge market in Massachusetts, is these are insured plans. There's no mandate to cover the weight loss drugs. And I defer to our DOI designee, but I don't believe the merge market covers drugs like this for weight loss purposes, but they would for diabetes.
Hi, this is Rebecca Butler from the Division of Insurance. I would assume that there are medical necessity requirements across the carriers. I have not investigated what those medical necessity criteria might be, but unless weight loss is medically necessary for a particular reason, my guess is that the drugs would not be approved in general unless there were some medical reason for the need for weight loss.
And from what I understand, they are being covered starting January 1st for Mass Health. I don't believe they were covered for weight loss indications in 2023. So that's another sort of, piece of market information, I guess, to take into account here. But I know Dr. Jeff Levenshires from WTW is on the line. And as far as the questions around, is this a good thing? I defer to his expertise.
Yeah, and before he does that, I just want to say that this is the challenges and opportunities, I think, with this drug are universally being struggled with, right, in health insurance. And I attended a conference in Washington, D.C. A month or two ago, at which a number of my counterparts in other states were there, and this was a very hot topic of discussion. And and concern. So this is a broadly felt impact in the marketplace. I think, as Vince said, it's a very recent trend that we've seen, and I think we benefit from more recent information that we can account for in the development of our premiums than others who have already set premiums, whether through the merge market or for the coming calendar year. So with that, Jeff.
Thanks, Matt, and agree. I mean, when we are talking to clients, this is very high on the list of everybody's thinking. To Valerie's question, do these bring value? The medical evidence for the benefit of GLP-1 drugs to treat obesity just gets better and better. For people with a history of heart disease in the past, they decrease major adverse cardiovascular events by about 20%. It looks like they end up being an effective treatment for fatty liver disease, non-alcoholic fatty liver disease, which can lead to cirrhosis. In diabetics, they decrease the progression to end-stage renal disease for reasons that really aren't all that clear. So basically, the clinical advantage of people who are obese, which is 40%, 40 or 42% of U.S. adults, the clinical advantages are great. Clearly, I believe that these drugs are priced way too high, and it's somewhat promising that tirzepatide, Zepbound, came out at, even though it's more potent, it came out at 20% less than Wegovy or semaglutide. There are like 100 or more drugs in the pipeline that are of this class, and so the hope is that the unit price is going to come down substantially over the next few years. I think it's not sustainable to pay this much for these drugs, but on the other hand, now that we increasingly understand that obesity is really a metabolic disease as opposed to just a matter of can't people get enough willpower or something, I think it is a medical condition, and and we can make many people's health much better with access to these drugs. Just also to put it in perspective, I think it's like 53% of plan sponsors with more than 25,000 members cover these drugs for weight loss. And also to, Vince, I think, brought this up. These drugs, sometimes in slightly different doses, are also used for diabetes. So if one doesn't cover them for obesity, there is a chance that a large, some portion of those people who might use these for diabetes, for weight loss might get them for diabetes. Clearly, they shouldn't be used for people who want to cosmetically lose 10 or 15 pounds. They really are for people with obesity, but they do make a very substantial difference.
Thank you, Jeff. Is there any payer or government entity that is having any kind of success negotiating value-based contracts for these drugs to, try to get the cost a little bit more in line with affordability?
I think that's a work in progress. I think there have been a number of states and other plan sponsors that have put in place programs that mandate some other, some behavioral modification program or something with these drugs. Unfortunately, that means you have to pay for that program as well as the drugs, and and there's not really evidence that these programs are especially beneficial beyond the benefit of the drugs. So I think that we still have to watch this carefully.
Yeah.
Hey, I am hopeful that we'll come up with a better way to pay, for instance, subscriptions or something else. We are working on that. So are many other people. There's been a bit of a shortage of these drugs, which makes Novo and Lilly, not apt to come up with deeper discounting or anything. But I think that shortage should be over very soon, and I think there'll be better opportunities at that point.
Yeah, thank you. I also need to mention that Commissioner McNamee has joined us, so thank you and welcome. And Toby, go ahead and ask your question.
So what I hear, either Jeff or Vince, that unit cost should come down in the near future as more drugs that have similar impact come to market. And then it puts people in a healthier state, which should mean less costs in other areas. So what's kind of that time frame? In other words, I'm skeptical that a lot of it's going to these medical areas. I mean, it's a designer drug for many people, in my opinion. But there are many people who really need it, so we have to cover it. So I certainly agree with that. So kind of for that kind of population, are we talking we might get the return on it 10 years? I mean, what's the thinking of the medical community where that return is?
Well, Toby, I think the drug companies really emphasize potential offsets. Obviously, if you're preventing a bunch of heart attacks and strokes,
Yeah, no, I agree.
People analysis, you should save a bunch of money. If you do the calculations, including critically looking at the drug company funded studies and the white papers that come from academic centers that have drug company funding and things, I mean, most medical interventions don't save money. They just make people healthier or save lives. And I think even at much lower costs, these drugs are not going to net save money. They're just going to make people healthier. But again, I mean, there's almost nothing we do except for birth control and childhood vaccines that actually is in the medical system that really saves money compared to not doing them. We do these things so that people are healthier.
Okay, I hear you, but if you're healthier, you have less heart attacks, you have less this, that, and those are very expensive, as you know.
And I mean, once you start counting, the value of people not dying prematurely and not having to replace people who, replace labor of people who might drop out of the workforce earlier because they're disabled or die, then you start being able to say, well, this pays off. But oftentimes people talk about cost effectiveness, and that's usually saying, well, does it cost less than $100,000 per quality adjusted life year saved? And I think people say cost effective, and many people hear cost saving. It's really just that you're paying a reasonable amount for the good things you're getting, not that you're getting these good things and a rebate with them.
Okay. Well, at least potentially the unit cost is going down.
That's what we hope for.
Thank you.
Yeah, and I just, if I may, Madam Chair, so Vince talked about two main drivers of the number being as high this year as it is. Certainly, one is the introduction of these drugs as a very new dynamic. In many respects, it's the repetition of a dynamic that we've seen before with other drugs. That have a high upfront cost for, I think, Toby, to your point, or to Jeff's point, kind of an unknown, undefinable, longer-term cost impact. But I don't want to lose sight of the first driver that Vince mentioned, which is the increase in provider unit costs. So this is essentially what we've talked with you about many, many times, and it's a story that we've heard that the Health Policy Commission talked about at our last meeting for sure, that provider prices, which have always been in Massachusetts the main driver, that is escalating, and we see that in the marketplace. We are in close touch with our carriers about negotiations that they have with provider systems, and those dynamics are changing. So we've had, the cost growth benchmark that the Health Policy Commission sets every year that has, one could argue had a beneficial impact on cost trend early on in the first few years of the Health Policy Commission. But the hearings this past fall at the Health Policy Commission, there were two health plan executives who really raised the alarm about provider systems in their contract negotiations with carriers, really not acknowledging or aligning with the benchmark in their expectations about how much they're going to be paid. So this has always been a problem. I would say this is becoming a more acute problem and is really beyond the GLP-1 drugs continues to be the primary driver of increasing premiums for us. I just want to make sure that we don't lose sight of that. And that's the reason we had Vince touch on that before we even got to GLP-1s. These are both challenges, but provider prices continues to be the primary challenge.
Yeah, no, thank you, Matt, for that. So a little bit of guilt on my part for, the shiny new ball of the GLPs versus the same old with provider increases in pricing here in our marketplace. So thanks for that. Eileen, I see you have your hand up, and then Bobby, but how about you go ahead?
Well, good morning, everyone. Sorry I was late. I do have a question about the unit price increases. Certainly that has been a driver for a number of years now, but what I'm wondering is, at one time it was because of brand recognition, everyone wanting to go to teaching hospitals. I'm wondering if that's still the case, or if it has to do with the consolidation in the marketplace, or if this is a way to make up lost revenue from COVID, or kind of all of the above. But if you have any insights into what are the reasons the unit prices are escalating at the rates they are.
Yeah, that's a great question. And I would say David Seltz could give a better observation about this than I could, but I'd say it is sort of an all of the above from my perspective. I think there are certainly some hangover effects from COVID-19. There's the well-publicized pressure that has put on labor costs in hospital systems. So we do hear that, but I think my bigger worry, frankly, is what I said I heard at the Health Policy Commission, that there is an increasing tendency to, I don't know if dismiss the benchmark is too strong a word, but it certainly is moving in that direction. And we heard from David Seltz at the last meeting about proposals that the HPC is making to strengthen their tools vis-a-vis the market in this place. So I think that's a response to what they are seeing. I will make one note about COVID. Certainly, it did have a system-wide impact, but it had a system-wide impact on top of a largely dysfunctional market for providers. As you note, the brand name and the market power that certain providers have allows them to negotiate higher rates. And those providers in that position didn't fare so poorly during COVID. And actually, financial data over the last few years that we viewed, that CHIA has viewed, really supports that. So the impacts on top of that market really put the most pressure on those provider systems that don't have that kind of market power, right? So we've read about Tufts Medicine's challenges in the marketplace. Those are much more acute than they are at Mass General Brigham, for instance. So so it's not uniform across the system that providers fared poorly financially during COVID.
So just sure, if I could just say one follow-up comment. So if the HPCs, the health cost benchmark, is having less sway over keeping prices down, I think one thing we could potentially do, or maybe Jeff knows this off the top of his head, but are the price increases in this market substantially more than they are across the country? I think COVID would be a national or a global phenomenon, but consolidation and less weight might be reflective of a more local market. So I'm just wondering if we can gather any data that would perhaps support that.
Yeah, that is certainly my view of the situation in Massachusetts. It is much more, and I wish we had Anna Seneko, our health economist, on here, but it is well documented that we have higher utilization of high-cost teaching hospitals here in Massachusetts, and the level of consolidation, while it's not by economist measures sort of at the top of the list for states, it is certainly in an area that is problematic to a well-functioning, value-based marketplace for healthcare services.
Yeah.
I might just add that when David Seltz presented, he showed that for the last 2 years that HPC was reporting on that Massachusetts inflation rates were substantially higher than national ones. There is lag in that. The other thing is, remember that we only have, I think, a year or two more on the Attorney General's constraints on Beth Israel Lahey's rate increases from that merger. So there is another sort of potential reason why they might feel that they've actually been constrained over the 7 years of the AG agreement, and they come out from that under that agreement in a year or two. So it's another concern.
Thanks. Bobby, do you have a question still?
Well, I actually, Eileen asked a lot of my questions. I was thinking exactly the same thing. But I wanted to know what the sort of impact also of primary care providers being fewer and fewer, that, I'm concerned about that as well, and what that impact will have, either the consolidation of primary care practices or, sort of people leaving those practices, as well as, staffing at hospitals, and what about the change with Dana-Farber and their new medical center, like the costs of all that, is that, I'm certain that's going to have an impact as well in future years. And if the benchmarks are being either dismissed or ignored totally, how can we sort of project, I guess, if the carriers are, ignoring those benchmarks, and what can we do about that? I mean, is that more a legislative issue?
Well, just to be clear, it's not, I wouldn't view it as the carriers that are ignoring it. From my conversations with our carriers, they are pushing hard, as we would expect them to, with providers that are asking, in some cases, just truly outrageous increases. So we follow this very closely. I would say more broadly, this is a policy question for policymakers, right? And I think we have the GIC, I would say, has relatively limited tools to address this, which is why we're, I think, fortunate to have the Health Policy Commission, who can really use data and analysis of market trends to propose the kinds of policy recommendations that they have and that David talked about in the last meeting. So we certainly, at the GIC, experience these dynamics in much the same way that the rest of the insurance market does. But we make sure that others in state government understand the challenges that we face, so that as they evaluate policy solutions, they can take that into account.
All right. Well, I don't see any more questions, and I don't I don't think we can solve for these type of issues here. I'm sure that WTW is taking note of our concerns, and hopefully policymakers may be as well. So if there aren't any more questions, let's move on. Thank you, Vince.
Thank you, Madam Chair, and thank you, commissioners, for the robust discussion here. We take this very seriously, as you can imagine, and working closely with our carriers to do what we can. So more to come, as Valerie said, these are things that we'll continue to struggle with, working together with you all. So next item on the agenda, I will hand it over to Andrew Stern, our General Counsel, to present on the proposed regulatory amendments. But allow me to give a little introduction here. As many of you know, the GIC has had a long-standing waiting period for benefits for newly hired employees, which has traditionally averaged about 60 days. And this has, as you can well imagine, presented a hardship for many who are joining the Commonwealth and our municipalities as employees. And we set out nearly 2 years ago to determine what it would take and what steps we would need to take to shorten or eliminate the gap in coverage that results from this policy. And as we discussed at our last meeting, the legislature included a provision in their FY24 budget that requires the GIC by July 1st of 2024 to offer insurance on the first of the month following an employee's date of hire. So this would significantly reduce and potentially eliminate gaps in coverage for new employees. So we've been hard at work on this even before the legislature acted. Our GIC project team has been working closely with our colleagues at an A&F IT to make the technical and system changes to meet this deadline. We're also working hard to make sure that our GIC coordinators are prepared for this change so it can go smoothly. But we also must update our regulations to be compliant with this new law, and that's what Andrew will be presenting to you today. As you know, this is from the last time we've done this. This is a long process with many steps, and Andrew's presentation today is really the beginning of that process. So overall, I just want to say that we're really excited about this project. I think it's long past time, frankly, that we address this, and we think it can be a tremendous benefit to our members who are joining us at the front end. So with that, I'll turn it over to Andrew Stern, our General Counsel, for his presentation.
Thank you, Matt. Thank you for the introduction. It makes my job much easier here. Next slide, please. So Matt was referring to the outside budget section. This is the text of it. It goes into effect on July 1st, 2024. So that's the point by which we wanted to have our regulations in place and modified. And while we're here today, as part of that work stream that Matt was talking about, Mark Tuttle, myself, Paul Murphy, and Donna Wortman took a look at our regulations to try to see what do we have to change, what was going to be superseded by this, what were some of the cascading effects, what did we need to do. So we spent about a month going through the regulations, and today I'm hoping that you got the material ahead of time that outlined the specific regulations we looked at, why we looked at them, and what the potential modifications are. We did tweak a couple that were not directly related, because while we were in the regulations, we figured we should fix things that had become superseded by other things such as statutory changes or changes in policy. Let's go to the next slide, please. So just as a reminder, our regulations are found at 805 CMR, Code of Mass Regulations, and we have basically 5 sections of regulations, and we're focused today on only 805 CMR 9 and the regulations in that chapter, which all basically have to do with eligibility and participation. Next slide, please. This is a reminder of the process that we now have to go through. So today we're here because we've looked at the regulations, we've drafted some changes, and we're here to ask you for permission to now move forward with the process of getting those regulations ready for final submission and publication. So today we're going to ask for a vote to move forward with the process, and then we'll be moving presumably to the next step, which is there's a whole process we have to do with A&F, which includes a cost-benefit analysis for each regulation we're changing, a small business impact, a regulatory impact, and compliance with an executive order 562. So that would be the next step. Then after they've reviewed things and we can move forward, we have to go to a public process where we notify stakeholders, we have hearings for the public to weigh in, then we take all that feedback, see if we need to change anything that we've proposed, and that could result in some edits. The Secretary of State's office will look at these to see if there's stylistic things that need to be changed. And after all that's done, we come back to you for final approval of the regulations and having them published. So this takes months, and we're at the beginning. With that, I'm open to questions on anything about the process, anything that we sent you concerning the draft. And when we're done with that, we can move to a vote.
I don't see any questions. I can imagine that there's a lot of excitement for this change, but it's also a lot of work. And it's the right thing to do for our constituents. Toby, I see your hand is up, and then Bobby. Go ahead, Toby. I think you're on mute. Yeah, he's still on mute. Okay, Bobby, how about we go with you and then we'll go to Toby.
Sure. I just wanted to, commend Matt and all the staff who worked on this, because this is probably one of the best things that could have happened in state government for our new employees, for new hires and their families. It's terrific to be able to have health insurance, pretty much within, like 30 days of hire. That's terrific. I know it's on day one if people are hired actually on the first of the month, but certainly within, 30 days, that's like phenomenal, because people will not have to wait, or perhaps, go on Mass Health or the connector to get health insurance for that, short period of time. So it's really terrific. And I just want to, applaud everyone on the commission who worked on this. It was, years in the making. So thank you all. I really appreciate it.
Yes,
Thank you,
agreed. Toby.
Can you hear me now? Can you hear me now?
Yes, we can.
Okay,
Perfect. Thank you.
Just a quick question, more curiosity, because I think it's the absolute right thing to do. I don't know how you recruit people and that for 60-day waiting period. So this is great. Is this a substantive amount of money that this is going to cost us? And is it been baked into our, if it is it been baked in?
Yeah, no, great question. So so I want to thank Secretary of A&F Matt Gorkowitz and Cassandra Roeder here today as her designee, and really the Healy Driscoll administration for supporting this, because yes, the technical changes do require funding. We've got capital funds designated to that, so there's minimal impact on our operating budget to do that. This really is it's an IT project, so IT capital dollars to support it is appropriate and certainly very much appreciated from our colleagues in state government. What I want to make sure doesn't get lost in this too, like this is a large technical systems change for the GIC. It also requires, what makes it particularly complex is that it requires significant adjustments to our process and our timelines and deadlines. So we need to be successful here. We need to make sure that those other state and local public entities with which we work are also making the changes to their processes, right? So there's a significant change management and communications and training aspect to this. But from a budgetary standpoint, Toby, this is largely handled outside of our operating budget.
And thank you. I didn't realize how big a change it was, so thank you for describing that. And the actual, they're on the, they start insurance, they start coverage a month or roughly a month earlier than they do today. And is there any impact of the cost of the medical care? Is that just something they're going to do it anyways? It's just moving it forward as opposed to eliminating or adding it.
Yeah, it is largely, as you suggest, it's largely a shift, right? Okay. So today we have, when folks start after that, on average 60-day delay, they do have coverage that extends on the backside of their employment. So for the most part, we're shifting that whole frame forward. There will be some budget impacts, but they're relatively modest compared to the benefit that we're producing here.
Thank you.
Yep.
There aren't any. Oh,
I see Eileen has her hand up.
Yeah, I just had a quick question. Does this change also affect the end date of coverage? So does coverage end on the day you leave, or does it extend, through a period?
I'm sorry, can you say that again, Eileen?
Sure. So I know that we're pushing up the date where people are eligible for their group insurance commission. And I'm just wondering if there's any impact on the back end when someone leaves, or does it end on the day they depart, or is it a period afterwards? Just curious.
So the tail of coverage past their employment will be shortened. I don't want to misspeak, so I won't say that it's on the day of their departure. If others on my team know the answer to that, they may chime in. But as I mentioned to Toby, the notion here is that we're simply shifting the coverage to be much closer to the date of hire. And I would say, one of the things that we've sought to understand through this project is what prior coverage from prior employment for an individual like this looks like. And in many cases, it runs through the end of the month of the date of their departure from their prior employer. So with us picking up coverage on the first day of the following month, we're hopeful that for many, if not most of our members, that there will be no gap in coverage. And those that may exist for certain people will be much, much shorter than it has been for many years.
Matt, this is Erica. I just wanted to chime in, and I'm sorry, I don't really have much of a voice, but the end date for insurance coverage for employees leaving the Commonwealth shouldn't have a big change to it, because the deductions will still be happening a month in advance. So they should still have coverage through the end of I believe the following month, following their employment. Like I said, because deductions are taken a month in advance, that would still have coverage.
Thank you. Makes sense.
Bobby, do you have a question?
Well, it was just, I guess, confirmation, I guess, that when someone is hired, the deductions will start on that first pay period.
Yeah, that's not
Is
new.
that correct? No. It's right, except it'll be earlier than it was before, right? So they would still be paying sort of a month in advance, essentially, or close.
I may ask
right?
either Erica or Paul to speak to how we're handling that.
Hi, Bobby.
aspect of it.
That's part of the challenges of moving the 60-day back to a 30 days. So we are still allowing an employee to have a 21-day window to elect their benefits. So that could potentially, if an employee takes 21 days, impact deductions for the next month. So depending on how fast the employee elects their benefits and we enroll them in our system, deductions will start immediately after we enroll them in the benefits, and we may have to bill for the missed premiums on some members because they've missed that deduction the way the payroll cycles are set up a month in advance. But that's some of the challenges we're looking at, particularly with our quasi-agencies and municipal agencies, which can make up deductions, but in some instances, we may have to bill the employee. But if they do it quickly and they elect their benefits, it is possible that we will get deductions the month before they're effective and no bill is needed.
Okay.
I just think it's really important to provide notice to people of that impact, right?
Yeah.
Because they may make the decision sooner and avoid having to be billed on the tail end.
Yeah.
Yes.
And are we putting all of that education in our portal to encourage new hires to get used to working on the portal and, seeing important information that's in the portal?
Yes, we are working with communications, Leslie, her team, with coordinators, and we are establishing information. We're creating new hire information in the member benefit portal, and it outlines all the importance of electing your benefits. You may potentially get a bill and the benefits of using the portal. So that is part of our lay of the land for communicating this, but we are working to make everywhere possible the communications about the new hire.
Yeah, and there are a lot of people to communicate with. So I do know how many different agencies there are. I mean, I think there's a lot. So if you can, at the upcoming education sessions, the public discussions in January, if we can reinforce the value of the portal and let people know how important it is to go there, because there's so much important information there. A lot of the agencies will be participating and listening in, and they can reinforce it with their constituents. So I don't think we can underestimate the power of communication and repetition and getting our constituents used to the portal and being more engaged more and more with online collaborations like this one. So thank you.
Yes, it's a good point, Madam Chair. The portal will play an important role in this, and as Paul knows and has let the rest of us know, there's we're creating a new tile, a new feature for new hires on our portal to make this easier. But there, as I said earlier, there is a substantial communications effort, both directly, communicating directly to our members about the portal. We always do that, and we will continue to do that. That's key to our success in so many domains. In this case, we're talking about new hires, so they're not members yet. So our channels to reach our members aren't as helpful to us specifically on the waiting period, but certainly for the portal. So we will continue to do that, but making sure that our partner agencies and their GIC coordinators and their leadership understand that this is a change that they need to be prepared for and preparing for is a big part of the work that we have planned for the coming months.
Yeah, great. Bobby, do you still have a question?
No, I just wanted to thank Paul for clarifying, right? Because I know it's going to be a huge effort because it's really dependent on the agency during their onboarding process. That's part of the communication. So that's a huge piece because GIC is not directly involved with the new hire. So
we'll have substantial trainings for our coordinators leading up to this change. That's very front of mind for us as a successful element to this project.
Right. Thank you very much for that.
Yeah, terrific. All right, if there are no other questions and I don't see any, I will I'll pass it on to Andrew. I think we have a motion here.
Yeah, I mean, I just want to say this discussion underscores how complex this is and how thoughtful we are in approaching it. And the regulations reflect some of the things that you have been concerned about the billing issues and how we're handling that. In addition, we've already prepared a couple of administrative bulletins to go to our partners, the coordinators in municipalities, offline agencies, to address some of the issues that you've also talked about. And with that, I'd like to ask for a vote to authorize us to move forward with these regulatory amendments and start the process so we can have them in place for July 1st.
Yeah. So I will entertain a motion that the commission authorizes Andrew, our longstanding and hardworking general counsel, to move forward with the regulatory amendment to get this this proposal into regulation.
So moved.
So Bobby's our first.
Second.
A second from Joe. So we'll turn it over to Andrew for roll call. And Andrew, I am a yay. Or
Thank
aye.
you, Madam Chair. Vice Chair Kaplan.
Yay.
Designee Roeder.
Yay.
Designee Butler.
Yay.
Commissioner Choate. I'll come back. Commissioner Davis.
Yes, I'm sorry, Andrew. I was on mute.
Okay.
Sorry.
Thank you. Commissioner Davis.
Tamara might be on mute too.
Yeah, I'll go to Commissioner Gentile.
Yes.
Commissioner Jennings.
Yes.
Commissioner McEnany.
Yes.
Commissioner Murphy Rodriguez.
Yes.
Thank you. Commissioner Sullivan.
Yes.
Thank you. And we'll come back. Is Commissioner Davis available?
I don't see her on the list. May have lost her.
Okay. In any event, it does pass unanimously of those voting.
Thank you, Andrew. And thank you, Paul, and the rest of the staff. We're really lucky to have such long-standing, dedicated team members at the GIC who know this stuff and can get it done for our constituents. So good work. Let's move on.
Thank you, Madam Chair. Moving on to our final item, substantive item for the day, our municipal insurance program, for which I will hand it over to Mike Berry, our Director of Government Affairs. Mike.
Thank you, Matt. Good morning, everyone. As you well know, I am not Santa Claus, but I do bring the gift of good news this holiday season regarding the municipal insurance program. So let's just start with some table setting. Next slide, please. This is just a reminder of all the municipalities and entities that are currently enrolled with the GIC for their insurance coverage. Total, it is 69,850 subscribers. We have 47 municipalities and regional entities. RSD, as a reminder, stands for Regional School District. And as you will see, we have quite a broad spectrum of communities that are enrolled with us. Also, as an additional reminder, our municipal population represents approximately 25% of our GIC membership. If you were to add independents to this number, we have about 115,000 men, women, and children that receive their insurance coverage through the GIC. Next slide, please. So we had 18 communities and school districts that were up for renewal this year, and I am pleased to report that all 18 entities have renewed for the GIC and or will be rolling over. The communities that are highlighted in bold are ones that actually requested their medical claims data. So that means typically in the April, May, June timeframe, they'll reach out to us and send us a formal letter requesting their claims data, and they will typically work with an insurance consultant to take those out to market and evaluate their options outside the GIC. So we did have quite a number of communities that requested their data this year, and credit should go to Lauren Makashima and the data analytics department for managing all these claims and turning them around in a responsive and swift manner. So thank you to Lauren for her assistance on that. We also have a new member to talk about this year. The Shore Education Collaborative, they are based out of Chelsea. They will be joining the GIC. We first had an engagement with them several months ago, I believe in the late spring, early summer timeframe. And we were in contact with them throughout the summer, as well as their insurance consultant. And they went through a pretty exhaustive process and ultimately decided that the GIC was the best option for them. So we received their letter of intent several weeks ago, and then recently received their executed PEC agreement. Again, PEC stands for Public Employee Committee, and we are happy to have them aboard. They have approximately 227 full-time employees and additionally about 30 or so retirees. So we will be working with the Shore Education Collaborative in the new year to get them ready for the annual enrollment process and help their employees with the transition. So it was a successful year. And as Matt said, we did have a number of engagements this last year with communities that were looking to join with our December 1st deadline. That's sort of the cutoff date, but I can report that certainly at any point in my 6 years here at the GIC, the interest was significant. And the education component, that we do here, I think has really been helpful to communities as they evaluate their options. So with that, I'm happy to wrap up and answer any questions that you may have.
Yeah, I don't see any. Do you anticipate with these impending rate hikes that potentially next year there'll be more municipalities? First of all, it's good work that we retained all of our municipalities. I think that's a great seal of approval for the work we do. And we did glean one new municipality or buying group. But what's your thinking for the future, given that rates seem to be on the rise at a pretty concerning rate? Anything to add, Mike?
I can take that first, Mike, before you chime in, but please do chime in after me. My sense on that is that we're likely to see a continuation of activity of municipalities to evaluate the GIC. We as I mentioned in our discussion about the projected cost increase, we are not alone on that front. So even those municipalities that purchase outside of the GIC will very likely be seeing trends that are similar to ours. But whenever that happens, it's not hard to see how a municipality that's out would want to evaluate coming into the GIC. So I think broadly, these increases are going to be seen across the marketplace. I'm sorry, Mike, go ahead if you something to add to that.
No, nothing really to add. Just anecdotally, I think as Matt said, this is happening across. So I don't think anyone is immune from rising healthcare costs. I did hear just from a one school district that is not in the GIC, they had to do a mid-year premium increase to deal with some of their rising healthcare costs. So I think we're all in the same boat here as far as healthcare costs. I think that the GIC just being a little bit better positioned than maybe some of our counterparts due to our size to navigate some of those cost increases. But generally speaking, I think it seems like something that everyone is going to increase across the board. So,
Bobby, go ahead. It looks like you have a question.
No, sorry. I just wanted to comment. I keep staring at this slide. I think it's terrific that all those communities have, requested their claims data and obviously, looked at other, let's say carriers, right? And decided to stay with GIC. I mean, that's really the best news. I mean, it's great news to have a new entity, but it's even better news that those who are up for renewal decided to renew with us. That's very encouraging. Do you know how many are up for renewal for next year?
I don't, but I can get you that information. One of the things that changes this is some of these communities will roll over for 2 years. That's mandated in our statute that if you don't execute a new PEC agreement, you will automatically roll over for 2 additional years. So most of these communities will roll over for 2 years. A couple of these communities have sent us updated PEC agreements in which they've negotiated a longer term. So once that happens, then I sort of go through my list and we'll say, if a community extended for 4 years, then that'll put them 4 years out. So once I tabulate all that information, I can certainly ensure that that information gets to you in the commission.
That'd be great. Thank you. Good work, by the way. Thanks.
Thank you.
All right. I don't see anybody else's.
Melissa has her hand up. Sorry.
Oh, sorry, Melissa.
Thank you, Madam Chair. I just wanted to anecdotally say that I was one of the communities that renewed this year. We did a full analysis using our consultant to make a determination on health insurance. And honestly, it wasn't even worth us going out to bid based on the value we were getting with the GIC. So I think that the communities that are in, we all did do our due diligence, but really the GIC is the best value at this point. So kudos to all of you for the good work.
Yeah, love the endorsement.
Thank you, Melissa.
All right, Bobby, are you putting your hand up again? Oh, it's down. Okay. Anybody else? Questions? Comments? Yeah, I mean, I would love, and I have a vision that all municipalities in Massachusetts would benefit from being part of the GIC. Just think about what kind of power and leverage we would have with the providers if we were all together as one buying group as a government entity in our state. So if you're watching, please take note of Melissa's glowing endorsement and consider the GIC and talk to Mike. He might have a poem for you too.
I haven't sent my letter to the North Pole yet, Chair Sullivan, but I will certainly add that to the list.
Yes, please do. All right. I don't see anybody else communicating. It's good work. I know we'd like to see more municipalities. It's always a topic amongst commissioners, and we know the hard work that goes into unseating status quo with the municipalities, but the value is there. So please join if you're thinking about it and you're a municipality watching. And good luck with our new GIC subscriber. Thank you to South Education Collaborative. So let's move on. Maybe give people a few more minutes in their day. Busy holiday time. Anything to bring up? All right. Well, I'm grateful for the opportunity to serve as the chair of this very important agency and the important work we do. I feel like I just absolutely adore the commissioners. I learn so much from them every meeting. And WTW for their smarts and brilliance and their help in navigating us. And of course, the staff, their dedication to our members and the expertise they have for so many things, not the least of which is, when someone turns 65, the amount of support that is given to our members to understand that complex turning point is just really amazing, amongst others, of course. So with that gratitude, I don't see anybody else wanting to bring up new business. So with the power vested in me, I am adjourning this meeting. I'm wishing you all a wonderful holiday season, and I will see you next year. Happy holidays.
Holidays to everybody.
Yeah,
Happy
thank you.
holidays.
Bye, everyone.
Holidays.